Welcome back to AME's facilitated sessions where mentorship and mastery unites to fuel your career in medicine. I'm joined with my co-host and expert facilitator, Dr. David Leon Taylor.
Welcome back to all of our medical scholars. It's another time for FS.
Yes. And I'm your co-host and moderator, Dr. Darren Wayne Jackson II. So we are in our season 4, and we already said, the med school closer, right?
That's right.
So this is episode 2, where now we've had our deep dive conversation about the step 1.
Yes,
Now, today's episode, you ready for it?
I'm ready.
The pivot to the wards.
We're moving on to clinical rotations.
Yes,
Here we
yes.
are.
So, and I'm glad you make that distinction because sometimes some of our, student scholars, there's a lot of different words that can mean the same thing. So when we talk about your now clinical years, now we've
Yes.
transitioned from the preclinical years to the clinical years. We've hear the word wards,
Clerkships.
inpatient,
Yep, inpatient.
clerkships. So all these different things are defining the now space that you're in, where you're not just in a classroom setting.
Yes.
You're now entering into that first feel of, being a physician, really
Exactly.
taking charge of caring for the patient from the beginning to discharge, right? So we talked in the first episode about the differences between step 1 and the MCAT. So just following that theme of differences, can you give us a few differences about, the scholar's experience from their preclinical years
Yes.
to their clinical years?
I have a great way to do this, Dr. Jackson. And of course, you haven't gone through the journey to physicianship. You are going to be the prime center of this experience that we're about to go through. Because I think it's important for our medical student scholars to understand this transition, as you know, they're going into their clinical experiences or the clerkships, wards, etc., inpatient service. I want you to start by thinking about the differences in your patient responsibility or the patient load. What was it like in your preclinical years versus the clinical years?
Okay. So preclinical years, I remember distinctly, we had this course called Patient Physician Communication, PPC.
Yes.
And so that was Georgetown's thing where it exposed the students first year to clinical cases and patients, in our first year. And so the difference between a PPC course where we did see patients, it might have been one patient that we saw in that class, for about 20 minutes. Then we bring that case back after maybe one other classmate saw a patient as well. And then we would come back and have the discussion about the case and about, and evaluate, your peer versus, how they did with the patient engagement. Now, during your clinical years, you may be seeing, depending on your school or the program, the clerkship that you're on, your census as a M3 or M4 can range anywhere between maybe 4 to 7
Yes.
patients. And this is over a course of a work day, and so you're not just, this 2-hour block or 3-hour block is, where you meet with your group for PPC and you walk over to the hospital and then you walk back and then you
To the med school, feeling
to the
good.
med school feeling good with your Starbucks,
That's right.
and then
I've been to see a patient.
Right. Whereas though, your third year, fourth year, your clinical years, you are, taking charge from, again, you're showing up in the beginning of the day, you're, doing intakes, you're doing history and physicals, you're seeing that patient through the door to the discharge.
Writing progress notes.
Right.
And
The whole
you're
process.
hoping for downtime to get a Starbucks.
You're hoping, yes.
Because you are
Yeah,
moving.
yeah, you are moving.
All day
You
long,
are
just like
moving
we've
all
all
day.
experienced and seen physicians move to the hospital.
Right.
So this first key difference between the preclinical and clinical years is the patient load is significantly different. And along with that load, eventually we're going to get to responsibilities in a moment, but I want to first look at time. What's the time like, the time expectation in terms of your preclinical years versus the clinical years, especially the start and end time of the day?
Okay. So, I mean, simple preclinical years, at
Hmm.
least my experience, what we had, most, a lot of the lectures were optional. And
Hmm.
so while class lectures usually started around 9 and it went to about
Hmm.
noon, and you might have some afternoon academic engagement with, groups or
Hmm.
lab, but for the most part, you could either show up or you can sign in from home and, watch the lecture
Hmm.
captures. Unless it was like a patient panel where it was a
Okay.
mandatory course.
Hmm.
Whereas though your clinical years, well, that then depends on your clerkship. So
Hmm.
let's just say, for instance, a surgery, clerkship where, I did my we had few subsurgical specialties within
Hmm.
our 12
Hmm.
week block of surgery. But, you're showing up to the hospital extremely early because you're pre-rounding. So you're
Hmm.
showing up maybe around 5 a.m., you
Ooh.
know, uh, because you have to be down in the OR
Hmm.
suite by a certain time,
Hmm.
scrubbed in and ready to do the thing. Whereas though, yeah, so that's a difference in the time. Whereas though in let's just say medicine, not medicine, let's just say family medicine,
Okay.
right? Family medicine, you're doing like outpatient. Has that more 9 to 5
Hmm.
feel.
Hmm.
You show up around 9 o'clock. You
Hmm.
leave around 4. You're seeing
Hmm.
patients throughout the day. A lot of them, because family
Yes.
medicine, you're seeing patients all
Hmm.
day, but you're getting there around 9 a.m. versus a surgical specialty where you're getting in very early in the morning.
Hmm. So now we see our start and end times are significantly different
Hmm.
as we now move into our clinical experience. And then that dovetails because with that time, of course, the time engagement, there's a role or responsibilities are different in the preclinical years versus now in your clinical experience. Tell me more about that.
So preclinical years is that kind of light touch.
Hmm.
You're getting that introduction, getting your feet wet. It's a lot more oversight. Um,
Mm.
but you are getting that patient experience, but the expectations of you carrying the load is very
Hmm.
low. Whereas though I remember distinctly, and I was still in my preclinical years, but I had some friends who had already taken step one
Hmm.
and they are now in their clinical years. And
Hmm.
it was holidays. We were coming back from holidays and, a bunch of us was in the car. And I remember they were all third years and they were talking about going to clinic as going to work,
Okay.
and I'm in the background, in the back seat, like, they're like, we got to be to work at this time. And I'm like, work, but they're
Yes, that's
speaking
right.
about, and I'm still in class mode. So
Uh-huh.
pre-clinicals, I'm like, man, I got to go to class and these suckers are talking about work,
That's right.
and I wanted to go to work. So I got that experience the next year, but that's the role difference. And you say work because when you show up to the
Hmm.
hospital, you know um again, you're taking on full ownership of
That's
that
right.
patient, whereas though, prior to, you're having that brief patient encounter. It could be once a week, once every
Hmm.
2 weeks, but for the most part, you have that mindset and that behavior of a student going to class,
Okay.
then going to the library.
Very, very insightful. So we're seeing now very targeted, focused differences
Hmm.
between the preclinical years and clinical years. And last but not least, because it's very, very important, what about your time as a learner?
Oh,
What does that look like? Your time as a learner?
yeah, so that's something that can really, um that can be a big shock,
Mm-hmm.
a big adjustment, learning curve,
Mm-hmm.
because you almost have endless time, you feel like,
Mm-hmm.
as a preclinical student. I mean, now it's not endless, but
Right.
you have lecture, and if
Mm-hmm.
there's nothing else to do for the rest of the day, you have all of that day to study.
Mm-hmm. To study.
And
Okay.
especially if you didn't even, go to class, if you just
Mm-hmm.
watch through lecture capture or
Mm-hmm.
online, you don't even have to leave your house,
Mm-hmm.
and so it gives you that, I have a lot of time to study and to acquire this information.
Okay.
Whereas though when you get into your clinical years, you may be working a 12-hour shift and you're looking for an hour in the day to study. You may not find that. You may get
Mm-hmm.
home at 7 o'clock and say, I still need to
Yes.
study, because, we'll talk about one of the other key pieces of your clinical years, which is
Mm.
the evaluation
Yes.
of
Mm-hmm.
your shelf exam, but you
Mm-hmm.
have to study. You can't just not study. You have to do your
Mm-hmm.
best, and show up as a
Mm-hmm.
clinical, third or fourth year
Mm-hmm.
student in the hospital. But then you also have to put that time in. So it becomes really limited once you get into your clinical years. And so that's when time management really,
Mm-hmm.
really will get you.
Always hearing
You have,
about time
yeah.
management. You hear about time management, elementary school, middle school, high
Mhm.
school, college,
Yeah.
and here we are in professional school, and we're still talking about time management, which is going to be so significant because of the level of responsibility that you're going to have. And as you noted in your clinical experience, you truly have to be a self directed learner
Right.
because there's so much patient engagement, but you're also learning from your valued patients. You're learning as you present to your attending residents. You're learning during clinical conferences, morning report,
Mhm.
bedside diagnostics. So there's a lot of experiential learning,
Mhm.
but there still has to be that self-directed learning with
Right.
the classic, could be on your iPad or it
Right.
could be the hardcore textbook, right?
Right.
All right.
So you're just finding the time to get it in. And so that is that those are the differences. So
Mm-hmm.
I'm glad you kind of broke it down like
Mm-hmm.
that, where you look at your patient load.
Yes.
That's a difference. You look at your start time,
Mm-hmm.
that can be a difference, and that can even be a difference within your clinical years, because that depends on your
Yes.
clerkship.
Mm-hmm.
Then you look at your role, the responsibility, the
Mm-hmm.
expectations that are now expected of you as a third
You're
year of
further
you.
along your
Now
journey
is
to
an AI.
physicianship. That's right.
Exactly.
And by the way,
Your
that
study
AI is
time.
not artificial intelligence. That's
No.
acting intern,
In turn.
which is a high level of responsibility, preparing you to move into almost your first year of residency,
Residency.
postgraduate training, right?
Right.
Uh-huh.
And so, there are some big differences, and I think it's very valuable for our scholars to be, cognizant that that transition does come in, and it hits fast,
Mm-hmm.
because that first day of clerkship, you're expected to have some of
Mm-hmm.
those things that we talked about in season 3, those
Yes.
EPAs. You need to come
Yes.
into the hospital day
Trustable professional
one,
activities.
right,
Mm-hmm.
with these competencies of patient care. And so, just that those things are out there. So,
Mm-hmm.
that's a great, segue into our second, segment, which we will talk about the evaluation, right?
Oh,
So
yes.
many students want to know, well, how am I graded in the second year? So you mean to tell
Mm-hmm.
me a resident or attending
Mm-hmm.
has to observe me and give me a grade?
Mm-hmm.
Well, isn't that subjective? How,
Mm-hmm.
so there's a lot of different, questions about, how are your clinical years graded?
Mm-hmm.
What is the standard? Because, does it fluctuate that much
Mm-hmm.
depending on the attending, depending
Mm-hmm.
on how somebody likes you? Or
Mm-hmm.
is there some type of, institutional standard that at
Mm-hmm.
least gives a baseline for the people that are evaluating you,
Mm-hmm.
how to, give you a representation
Mm-hmm.
of what you're doing in clinic.
Mm-hmm. Well, I like the way you frame that. And I'll note first that we're going to talk about an institutional standard, or a
Mhm.
standard that goes across all of what we call undergraduate medical education and even graduate medical education. We sometimes give different frameworks. But I do want to give one caveat that's a whole nother facilitated session, that yes, sometimes there may be a bias in the evaluation of scholars during their clinical years, because you have both a subjective evaluation, which is supposed to have an objective framework to it. It's
Mhm.
kind of a paradox. And that's where you're being observed by a resident or attending physician with respect to your clinical skill sets.
Mhm.
So there are technical skill competencies, but also in terms of your clinical knowledge and reasoning, because you have to problem solve around the patient's concern.
Mm.
And so there are some objective measures of that process that are standardized, but it does have an element of subjectivity to it based on the person who's evaluating you.
Mm.
So that will be a separate, of course, facilitated session, how to navigate if there is inappropriate, um, shall we say, uh, uh, commentary that may not be anchored in, let's say, authentic observation, right?
Mm.
That's a
Mhm.
diplomatic way of putting it around bias.
Yes.
Is that right?
Yes.
That's some
PC.
good
Mhm.
diplomacy around that, some
Mhm.
good PC. Now, Presuming that we do not have bias, we do have a structured process. And one of the processes we use, we call it a taxonomy, which is a classification scheme.
Mm.
It's called RIME.
Mm-hmm.
RIME.
I remember that.
RIME.
I remember seeing that
And
sheet.
RIME, that's right, has a standardized process in which we can evaluate how you are developing now as an aspiring physician in your clinical experience.
Mm-hmm.
And we'll take it in parts. The first, the R, stands for reporter.
Mm-hmm.
Can you share the facts about your patient? You remember that, right?
Mm-hmm.
So you were asked to present some information about your patient.
Right.
What would that be?
If I'm just operating as a reporter, I mean, you take a history and physical, and then you come back to your attending or your resident, and you give them basic information.
That's right, that basic information. That's exactly it. It's
Mhm.
that straightforward. And when you're first starting out, as you know, as a medical student, sometimes that's intimidating
Oh, very
because
intimidating.
there's a lot of information that we're training you as an aspiring physician to gather from your valued patients. And there's a process, a system for that. So being able to demonstrate the competency of being a reporter is critical. That second level, the I in RIME, is for interpreter.
Mm.
And this requires you now to take all the information you gathered from your patient, understand it in a meaningful way, and then develop a list of possible diagnoses. What is going on with your patient, right? So that list of possible diagnoses we refer to as differential diagnosis, right? What's that like? What's some of the skill that's involved in developing a differential list, if you will?
Well, I mean, that's where the integration comes in. So we're looking at key things about our patient, case to come up with the most likely answers.
Yes.
And in terms of what the diagnosis could potentially be. So you may be looking at vitals, you may be looking at labs, you may be looking at, imaging, along with the patient's history
And chief complaint,
and
of
then
course.
chief complaint for, their presentation today.
Mm-hmm.
That culmination of information gives you information to be able to create a list of what the possibilities are. And I know when I was in school, we did it like a tiered system as well. So, we came up with a differential where, like, category 1 would be the most likely things. Category 2, possible, based off of this, but more workup is needed. Category 3, this is what we call zebras. This is not really the case, or maybe something very rare that's less likely to be it, be the situation. And so that's kind of the process of differential, of creating a differential list, is not just zeroing in and focusing on what
Yes.
off the cuff you think it is, from the patient's presentation, but really integrating key aspects of that patient's history and physical and everything that you're seeing in the EMR to come up with a possible answer and go from there.
That's very insightful, because I can already appreciate, first of all, why mastery learning is so important, because there's a lot of core preclinical information that you've learned that goes into understanding all of these components of the patient's presentation. And then, as you said, the additional learning is when you're categorizing what is most likely versus moderate likely versus least likely, you're doing that based upon your integration of all of your medical science, right? So that you can see what might be relevant. And that's part of the training.
Right.
And
because in practice, you don't necessarily do it that
exactly,
way.
exactly.
In practice, I'm not seeing a patient. I'm like, oh, it's most likely this, moderately likely this, and less likely that. But in learning how to develop a differential diagnosis, that's how it was framed to us. Because highlighting the importance of not focusing in on what the most likely case can be. Because, this patient may present pathognomically as, a cholecystitis, right? But there might be something else hiding in this case that might be that you have to be careful about before you make that before you make that diagnosis that this is it. And so, kind of taking us through the categorization of most, moderate to least gives you that understanding. But like in practice in the hospital or in clinic, you're not necessarily doing it that way.
And what has actually happened is that, based on this practice, you are developing a skill of caution, but also efficiency, because timing could be of the essence in treating the patient.
Right.
So now when you get to the practical component, this process is actually happening mentally very fast, but then you're expected to give your top 3 differentials.
Right.
But in essence, in your brain, that 3 categorization has happened, but it's happened rapidly because of the training. That's really, really insightful and impressive, which reminds us of the requirement of learner accountability in that process. So when we move now from interpreter, we see that as we move through the RIME schema, it becomes increasingly more complex with respect to the responsibilities that you have.
Right.
Because after reporter and interpreter becomes manager. And the manager now, based on those first 2 components, being able to report out what's going on, understanding it, coming up with the differential, you now are going to create what's called the assessment and ultimate plan for the patient, right? Tell us more about that.
Oh, the assessment and plan. The A and P of the SO of the SOAP of your note. So the assessment and plan, that's where, that's where the big bucks are. That's where you are demonstrating to, your evaluators your ability to do all of the stuff before. I can report by giving you the pertinent information that you need.
Pertinent.
Right. I can be an interpreter because through my assessment and plan or my assessment, I'm taking all these various different pieces of this patient case, from the imaging, the radiology, to the history, and I'm interpreting, coming up with a differential diagnosis, and through that, now as a manager. Now, what am I going to do with all of that? What do I assess and make the final decision on the diagnosis? And then what is the treatment plan?
Yes.
And so that becomes, something that's key and vital with your note, because doing that a lot of times early on in your career, your resident is helping you a lot with that assessment and plan part. You get used to it after a while, but the resident is kind of helping you with the learning of even writing it, because you can know the information, but even the communication of it in the EMR to other doctors when they see it is also, a learning thing that you have to
Which
know.
it's an expected competency and part of the entrusted professional activities, because it's the way physicians communicate, but it's now also part of the important electronic medical record, the EMR, from which everyone will be accessing to support the patient.
And that will see your name on that
That's
note.
right. It will see your name. So there's a lot going on in the evaluative process here in the RIME schema. Now, when we get to E, educator, now as the resident has helped you understand how to do this process, there is a teaching tool in medicine that we say, teach one, do one, right? And do one, teach one. So now you will eventually be able to teach the residents, the attending physicians, your peers, some aspect of medicine, right? As an educator. Is that what's happening?
Yeah. So you can do the education part of morning report, or morning rounds if you're doing walking rounds and you're educating, all the way to grand rounds, or didactics, where you may be in a particular setting with peers and senior colleagues to educate them on what the case was, the different aspects of the case. Maybe this is a very unique case that called for this type of education where we're teaching.
Wow. So this RIME schema, therefore, is really critical as part of how the medical student scholar can actually espouse their learning, their clinical skills, to be able to meet that competency, so they know this is how I'm going to be evaluated, and therefore comport themselves accordingly. Well, let's play with it a little bit. Let's run through a RIME, if you will, schema for a particular patient. And I'm going to give you a case. We'll just make up a case on the fly. I know you love this. Again, a physician having gone through the journey.
Right.
And then we'll break out the elements of reporter, interpreter, manager, and then potentially educator
Okay.
in this system. So let's say you have a 23-year-old female college student who presents to the student health clinic, uh, and she has a fever, high-grade fever. She has nausea. She's complaining of a headache. She's complaining of a lot of tension in her neck. It feels very stiff. And she reports this has been going on for about the last 4 days. She also notes that she also had a friend in her dorm who also has been sick for a few days, but hasn't come in to see anybody. She has no other pertinent medical history, pretty healthy. She's on no other medications. All right, that's the presentation. What do you want to do with that?
So we have a patient who's coming in. Some of the first things that stuck out to me was, maybe this is how I train my mind. So demographics, right? So, as a reporter, I'm reporting the fact that this is a 20-something female who, you said dorm room, who's coming in febrile, with some neck stiffness. So off top, to me, from where I am now, that sounds like a clear case of meningitis, right? However, you know, the reporter, taxonomy of it is kind of just reporting back
What
the
it is.
pertinent information, the
Exactly.
high yield information from the history.
That's right.
Yeah.
And then the interpreter is doing what?
The interpreter is now, thinking meningitis versus some other infectious or
Such
other
as?
process, maybe flu. You're talking about, and I don't know
What
if you said
about
like
mono?
night sweats,
Yeah.
mono, so all of these, like, things that fit somewhat into that box with
Right, because some of
meningitis,
the symptoms and then
they
some of
overlap
the
a little bit.
context, a college student dorm, it may overlap. So it lends itself to some of these other possible conditions, but they may not have all the sequelae,
Right.
which allows you, as you say, to come up with, in essence, as you move toward management,
Right.
a final diagnosis and assessment and plan.
Right.
So you're thinking meningitis, what would you do for the patient?
So as a manager, a meningitis, you want to do a LP, lumbar puncture. You want to get, cultures, gram stains. You even want to give empiric antibiotics, because, a meningitis, especially if it's a bacterial meningitis, this is what it's sounding like because of the presentation, the severity of the presentation. You want to do those things. You want to confirm through that lumbar puncture, getting that cerebral spinal fluid and seeing, evaluating the CSF for the bacteria or the virus. And then you want to give the empiric antibiotics. You want to do all of these, things, but you're not waiting, until you're not waiting to give these antibiotics, because this could be, in my mind, in my differential, this could be a meningitis. Whereas though if it's a flu or mono, the severity in terms of how quick I need to get on board with the treatment may not be as much, but I don't even want to take that chance. So I'm going to give the empiric antibiotics. But this is what I'm communicating as a manager, and it might be a little bit more truncated, but when I'm in conversations with my attending, as I'm giving my report, or my senior resident, this is what I'm, talking out to them,
Right, and of course, then working together as a team
Right.
to confirm, okay, this is a diagnosis and what will be next appropriate steps.
Right.
And then we move you to an educator role. You might give a presentation, let's say, on differentiating between meningitis or another common condition in college students.
Right.
Maybe give that as a presentation for a clinical conference or something as a way to help us understand as peer medical students common presenting conditions in college student populations
Right.
with which you should be able to differentiate.
Right. Even, down to like the management, like medications and stuff like that. So these things can be, teased out in this scheme of, RIME. So that brings us to, our third segment, where we talk about another evaluation point of our clinical
That's
years.
right.
So, we talked about the eval,
Mm-hmm.
which, is going to come from somebody that's observing you.
Mm-hmm.
So it's more of, some observation with that standard of rhyme, right?
Mm-hmm.
But
Mm-hmm.
for the shelf exam, these are your clerkship exams. These are high stakes exams
Mm-hmm.
that you get after every clerkship.
Mm-hmm.
And this brings in what we talked about in terms of the differences, because time, right?
Mm-hmm.
Depending on the clerkship, depends on, dictates how much time you have to study for that shelf exam.
Mm-hmm.
And like I said before, if it's a 2-week clerkship, your exam is in 2 weeks. If it's
Mm-hmm.
4 weeks or 12 weeks. And so just give us a little bit about, your strategy,
Mm-hmm.
or our scholars' strategy when they are going into a clerkship, because as you said before, you want to start at the end. When is the exam,
Right.
and then kind of work your way up to
Mm-hmm.
day one. So give
Mm-hmm.
us some strategies on what to do with this.
Well, in a nutshell, as we know, you have to be a self-directed learner,
Mm-hmm.
and you always want to think about the endpoint, which is the clerkship exam, which is a multiple choice exam, approximately 110 questions,
Mm-hmm.
that goes across the breadth of what you're expected to know in terms of clinical knowledge
Mm-hmm.
and reasoning for family medicine, internal medicine,
Mm-hmm.
obstetrics, gynecology, right? Depending on the clerkship, surgery, etc. So, with that said, I need to consider at the beginning of the clerkship,
Hmm.
okay, my exam is on this date. What's going to be the learning resource that I use each day in preparation for that exam at the end?
Mm-hmm.
So remember, in your clinical years, you're learning two ways, right? You're learning throughout all your clinical experiences, right? Presenting to your attending, the
Mm-hmm.
residents, evaluating your patients. But you also have to do independent learning each evening, if you will,
Mm-hmm.
utilizing that resource. And I saw you said, because that
Yeah.
goes to the time,
You said,
right?
yeah, each evening.
Right. So
If you're
that
lucky.
proactivity and working with your clerkship faculty will have recommendations of learning resources. Some will be required, some will be recommended,
Mm-hmm.
that you will use as part of your longitudinal preparation.
Mm-hmm.
So let's say if it's a 6-week clerkship, then within 3 weeks, about halfway through, if it's a 4-week, 2 weeks. If it's a 2-week, 1 week. If it's
Mm-hmm.
8 weeks, it's 4 weeks. Halfway through, you should have digested, if you will, the knowledge resource for that clerkship. Now,
Mm-hmm.
for some, it could be using videos to get that knowledge enrichment. For some, it may be a textbook. It could be a review book. So again, that's individual learning preference, right?
Mm-hmm.
But you're gaining the knowledge. And so setting aside, usually most scholars will have only about 2 hours a night
Mm-hmm.
because they're already exhausted from the clinical day.
Yeah.
But you have to do that longitudinal enrichment. That's happening Monday through Friday. Then on Saturday and Sunday, you can do a few practice questions.
Mm-hmm.
And that would be from any one of the practice question banks we said before, UWorld, USMLE RX. So in thinking back, on like the first half of your clerkship, was that pretty much like your rhythm, what you tried to do?
Yeah. So I mean, not as structured as you laid it out.
That's right, because a lot of times people are
You,
trying to find the way
you
with
trying to
just
find
the
your way.
just the clinical experience day responsibilities.
Exactly. And that can be a learning curve.
Mm-hmm.
So, but yeah, you start off, the clerkship, at least knowing what is required for, the exam.
Mm-hmm. Mm-hmm.
What do you need each day? Because different clerkships might require different, instruments, and so you get a lay of the land through understanding what you need to have for that clerkship via the resources to study, and then also via what you need to do on a day to day. So it's similar to what I did, but just not as cohesively put together like you just did, like you explained it.
That's right. And then the second half of that clerkship experience, what you're focusing now on is more practice questions, again, in smaller segments in the evening. But we also have to have at least 3, and this is where you may have to adapt it depending on the length of the clerkship experience, but at least 3 practice assessments, the ones that are predictive
Mm.
for the actual shelf exam.
Mhm.
Now, remember we said in a previous FS, the only predictive assessments are the MBMEs.
Yes.
They have MBMEs for the clerkships. They're actually called the Clinical Master Series. The Clinical Master Series. And these are retired practice questions from your Step 2 CK licensure exam that have now been broken up by clerkship.
Okay.
And you can use those as a gauge. And so if you have a 6-week clerkship, of course, you would do one in week 3, week 4, or well, week 4, week 5, and week 6. If it was a 2-week clerkship, remember there's going to be less of an information load, and a lot of 2-week clerkships do not have a clerkship exam. It may be enough of a competency, so you're not as concerned there. But if it's a 4-week, you'll have 2 weeks to get ready, and so you make adjustments. If it's an 8-week, you have 4 weeks to get ready, etc. Right? So you make adjustments. But the point being is that in knowing in advance, that's what I'm going to use for my predictive indication of readiness. I can secure those from my MBME portal. And remember, you always have access to that because that's part of your licensure registration. And in those first 3 weeks or 2 weeks prior to doing those questions, you're doing the Q-Bank questions, which are not predictive.
Right.
They're just progress.
Progress.
So
But
having that frame at the beginning is going to be so important so that you can be ready at the end.
so it's funny, you talked about resources, right? And we keep going back to MBME, being the predictive resource, for the step exams. But now, we're also hearing that as a predictive measure to take for your shelf exams. And it's so funny because it brings me back when I was doing my OB-GYN rotation. And there was so much distinction amongst the group about what do we use, because there were some practice questions, I believe, from maybe the MBME context, but then there was also these questions from ACOG, which
Yes.
is the body of physicians for the OB-GYN
Right.
specialty.
Mhm.
And
So
so
the American Board College of Obstetrics and Gynecology, right?
yes. So on the website, they offered like a lot of questions. I just remember going to a website, it had like green on it, and it was like questions.
Mm-hmm.
And just being nervous about dedicating the time to
Sure.
that versus other resource. And throughout the 6-week course, I remember at some point I'm just like, I don't know if this is going to cover it all. You're looking at some practice questions, and it's just like maybe these are not as similar, but this is ACOG, versus. So I think that that's a good thing to highlight,
Right.
because going back to my medical school career, medical school experience, I remember, at some point you start to look at the resources to start studying.
Right.
And then you're assessing how the exam is going to go from there. But when you have some, clerkships that might have a variety of resources, and you're getting, 1,000 opinions about what's the best resource to prepare for the shelf exam, I guess, you're telling us right now, it
Right.
is going to be the MBMEs.
Right. We can break it down in 3 levels. So first level, the most significant and most important are the MBMEs, or the Clinical Master Series for the clerkships, and they're divided by clerkship. Those are your predictive assessments, and those should always be done in the second half of your clerkship experience, because by that time you would have done enough practice with knowledge enrichment and other practice questions that are not the MBMEs. So that's top tier. That's number 1. The second resource for any clerkship, pediatrics, family medicine, OBGYN, radiology, surgery, each of those individual clerkships, the specialty organizations, the Society of Radiologists or Family Medicine Practitioners or OBGYN, etc., pediatricians, each of those societies have practice questions at the resident level and at the medical student level. those are high value because they're written specifically for that clerkship context. That is your second best resource. It's a progress metric, but it's much stronger than the third level, number 3, which are the commercial question banks. The commercial question banks, remember, are following the blueprints of any of these societies or MBMEs. And again, they recruit faculty who are experts in those areas to write questions, but everything is relative. So if you want to know what to use, it's MBME Clinical Master Series, second half of your clerkship, first half of your clerkship. If you have limited time, the preference is the society or specialty or clerkship specialty, their practice questions. And then third would be in the commercial bank, which would be U, World, Kaplan, etc. In that order. And you'll always be in good shape because you can't use everything.
Yeah, you can't use everything. And so, I'm glad that you broke it down like that, because ultimately the theme from last episode for step 1, MBME practice questions, most predictive. Shelf exams, MBME practice questions, most predictive. That's warming us up for our next episode, as we're closing out today's episode, where we will talk about the USMLE Step 2 CK. And I have it titled The New Standard. As we talked about already, step 1 being pass fail. So we'll talk about why I titled this The New Standard when we get back. Before we close out, of course, I want to remind our scholars that we have our clinical wards checklist, a resource guide at our AME website. And you can go over there and download that at your earliest convenience.
That's right. So until then, we'll see the scholars in our next FS.
See ya.